Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and this morning I'm with John. How are you doing today?
Hey, how's it going, Dennis? Thanks for having me.
Hey, I really appreciate you coming on. The main reason, other than I just wanted to chat with you, was since you're on the TCCC Committee, and I know there's a lot of changes coming. We don't know when quite yet, but since you're on the committee, I'd kind of like to talk to you about some of them changes.
Absolutely. So anyway, TCCC is it's always being updated. It's always being changed. And kind of the way that works is, somebody is identified on the committee as like a working group or sub-working group, kind of leader. That's kind of like what I did for, the chest trauma update. So they basically identify somebody on the committee to kind of lead the change effort. And then you're either assigned or recruit, additional committee members or people in, your community. And then you kind of work through, updating that specific section, whether it's respirations or airway. And, you go through a pretty extensive literature review. You go through casualty ARs, you ask people, their different experiences and anecdotes from, their operational time or deployment time. And then, you kind of take all that and, review it and then try to figure out, is TCCC still relevant in that area? Or does it need to be changed? And then you present it to the committee. And the committee is quite a few people. And then you're given feedback. And then you kind of go back and forth until, some of it's compromised, some of it's data driven, some of it's experience driven. And some of it's just based on strategy, whether we're prepping for GWAD or we're prepping for LISCO. So that also, I think, has a lens to the change. So you just kind of go back and forth until you kind of hit all those requirements. And you propose a change for a vote. And then it's voted on. If it's voted yes, then it's added and updated on deployed medicine. And if it doesn't get voted on or it doesn't pass vote, then nothing changes. So it's that kind of in a nutshell kind of how it works.
Nice. So the committees, once a head has been tasked, is it generally docs, PAs, or do they try to get a broader mix in that working group?
Yeah. So the working group, so even like the leader of the working group can not be a doctor or a PA, it can be a medic. The airway update was a fantastic update, very relevant. I think it was probably our most recent change. That was an enlisted guy in the Air Force, DJ, squared away dude. And he did a great job. And whether it's a doc or a PA or a medic, kind of leading the change, everybody kind of comes together and, supports one another. Make sure we put out something relevant. So yeah, it can really be anybody on the committee.
Perfect. No, and I also think it's also very smart because everybody has their own experiences for whatever levels, you know what I mean? The next question. Yeah, I'll figure it out. But, dang, I should have wrote it down.
It's okay. You want to talk about some of the changes?
Yeah.
Going through on the committee?
Oh, I'm sorry. I finally cranked up. A coffee finally hit in. So
there you go. Yeah.
So when you're doing your literature review, you're going over the guidelines, you're going over all the data, right? When I tell my students, and I just want to make sure that I'm actually telling the truth, when you come up with an algorithm, generally there's like a patient somebody has in mind, and the algorithm is to now save that patient, right? And it kind of goes into one of the changes you're proposing, I think, resuscitation before decompression, right? One, is that even true? Or I'm just making this up? Or like, how do you decide? Because there's the variance in trauma patients can be enormous, even if you're talking chest trauma. So how do you kind of narrow down, like, these are this type patient will do the most good for the most people? If that makes sense.
When I when I started evaluating the respiration section of March, so the R, that specifically addresses tension pneumothorax, which is one of the preventable causes of death, which is, pretty well established. It's old thought. And I think as we try to update it and research it, it's really the incidence of it, or how frequently it occurs isn't very frequent, actually. It's still a preventable cause, so it's important. But I think the real issue we're addressing is hypotensive patient. So there's a couple different ways you can be, all hypotension and, kind of our population is caused by shock. But it's then it turns into what type of shock? Because tension pneumothorax is an obstructive shock. There's also hemorrhagic or hypovolemic shock. And then without kind of some of the medical niceties or some of the medical imaging and stuff like that is commonly found in medicine, as a medic, figure that out. And so then that's really where we thought, we should probably start resuscitating first, because hypovolemia and hemorrhage are way more common on the battlefield than an obstructive cause of hypotension. And then you take that a step further, and it's really the mortality benefit, fluid or blood resuscitation. The median time is 36 minutes, and then it really starts around 15 minutes if you look at some of the papers from 7 or 8 years ago. So that's kind of how our problem resolved for the resuscitation update, or the respiration update, to pick resuscitation over a chest intervention. I think the update is to be applied to all combat casualties in general, and to do the most good for the most patients, most common patient experienced, in combat. And also to give it a little bit of wiggle room for that, the kind of some of those exceptions where, you do have an obstructive cause or something like that. There's still verbiage in the guidelines that can allow a medic to kind of figure that out and do the right thing.
Yeah.
Yes.
No, I think in general, it's a very smart plan. Start resuscitating before decompressing the chest. One, it's pretty damn easy. You get some kind of access. You start pushing fluids. Full resuscitation is not done, but you've just at least started, which I believe is all you're asking. At least start pushing fluids.
Right. And even in obstructive causes of shock, pushing fluids will still help them anyway.
Yeah, absolutely. The obvious, type of shock that fluids are going to help, hypovolemic hemorrhagic. That's obvious. Obstructive shock, first intervention, start giving some fluids, trying to build that pressure up to get it around the obstruction to help circulate. Neurogenic, start giving them fluids to start filling the tank before we start squeezing them. Distributive shock, same thing. So if you're going to throw a dart at a board, you'd probably do pretty well to throw that fluid dart, because you're going to help at least in a variety of different types of shock. The only one I think fluids probably wouldn't be super helpful is cardiogenic, but if you said, Dennis, you're wrong, I would 100% believe you.
Probably need some level of fluid cardiogenic shock case, but fortunately, we won't really, that's pretty complicated.
Yeah.
Fortunately, we probably won't deal with that.
Yes. I hope not.
Yeah.
I hope not. So that absolutely makes sense. Start with fluids and then start worrying about the actual tension, or at least it'll help you suss out, is this a tension or is this just a hypotension problem, right? And that obviously goes with all our assessments. So when we talked last, when we first talked about chest management and the whole idea of giving fluids before decompressing the chest, we talked about the algorithm doesn't really lend itself to that because it's, massive hemorrhage, airway, respirations, then circulation, and as intelligent and as facile as we want our medics to be, and we, believe that our medics are, some are not, right?
Yeah,
So
absolutely.
They will doggedly follow the algorithm till the end, right? So we mentioned, how are we going to kind of fix this issue, especially when it comes to training, is how are we going to fix the March algorithm to kind of facilitate that transition?
No, that's a great point. Just the way I look at, the March algorithm, it sets up priorities of treatment for the medic to treat a casualty. And so we initially proposed maybe 6 to 12 months ago, switching around March, kind of changing up the alphabet. And we went through a couple different iterations, we initially went with should we change March to match, or T stands for transfusion? We tried all these different variations, proposed them, and it went back and forth, kind of like previously discussed with committee members. And those conversations are actually still ongoing too. So there's not a defined answer for it yet. But basically the final proposal was, to keep March, and then switch the R with resuscitation and the C for circulation. And that's kind of where it ended. So you would resuscitate first, then you would go into your chest interventions.
Oh, C to chest now?
Yeah, C to chest. Yeah.
Perfect. All my t-shirts and stickers will still work now.
Yeah. So a lot of you just got to change the meaning of them and stuff. But there's also other proposals out there. They think maybe resuscitation should start in massive hemorrhage. And then you just keep R, respiration, and then C, circulation, additional stuff. And then it's even kind of gone further. So now we're just kind of reviewing March in its entirety. And we're just really evaluating to see if everything that was added is really in the right spot. So pelvic binders, tourniquet conversion, all these other factors, where they lie in the algorithm. Is this still relevant? Because initially March, it wasn't designed to be sequential like that, or the initial idea of it didn't really mean to have sequence to it. But over time, and I think with training and the way military service members are trained, it kind of does become a sequence. So, I think some intent probably got lost, throughout time, but that's why we're reviewing it now, to make sure that it's still meets, everybody's requirements and needs. But yeah, so that's an ongoing thing. And, there's lots of smart people throwing great ideas and forth, and probably more to follow on that one.
All right. I'm 100% biased. I definitely like keeping it March. But
I'm biased too. So I proposed, the resuscitation chest one. So that's like what I want to go with. I'm not scared to admit that or whatever. I think it makes the most sense, and data supports it pretty well, and what we know to be true supports it well. So, and just what I've seen, and COSC AIT, because it's got a bite just not too soft, but E3, been in the Army 180 days. I mean, that gal's got to be able to use this stuff. So yeah, it's just my own bias and the lens I look through.
Yeah. And the military, we love algorithms, we love lists, and so something like an acronym like March just kind of lends itself to something like that. I 100% understand, Frank Butler and et al. There. We're more free thinking as far as, hey, this is just a conglomeration of things to do. But that doesn't really lend itself well to big Army, at least anyway, because we have to have it in a list, right?
Absolutely. Gotta have a list.
So chest management, that's up for proposal or up for a vote, or are they still reviewing that?
I think it's going to be up for a vote the next meeting we have, and have roughly, there's quite a few changes. So yeah, just based on kind of what we know now about blood transfusion, its mortality benefit, and the timeline essentially pneumothorax takes to develop. We have restructured the respiration section quite a bit.
Yeah. It definitely sounds like a pretty massive kind of overhaul of what was to what is being proposed now. So other than the chest, unless there's anything else you want to add about the chest, but other than the chest, another, I think a very important area that is kind of being force changed is the analgesic section there, because the manufacturer's not making the fentanyl lollipops anymore, and so we have a dwindling supply. Do you have any ideas about what they're going to do? Are they going to go with the sufentanil or a rock? Like what? What are they going to do?
Definitely a rock. I would depend on that. Yeah, the analgesia part is tough. I don't know. We talked about it at our last meeting, and I didn't think we found a lot of solutions yet. But there are people talking about it now, trying to figure it out. I know that I think we talked previously about ketamine auto-injector. We're very ketamine heavy in our protocol now. So, without fentanyl lollipop, you could either, go more ketamine, which we kind of already have. We could do, IV fentanyl, which I think pretty safe depending on the dose. And then, I don't know if it's FDA approved, but there's also the green whistle. The Australians use that. I'm very interested in that. I don't know something about it though, but I like the idea of kind of self-administered pain medicine. So I think you can do it with the whistle, or you can, assist somebody take it on. It's pretty small. You can keep it in your pocket. Doesn't require a needle. But I don't know if it's supposed to be. So that's one of the limitations, I think.
Yeah.
But,
personally, that would be my choice. Would be that that green whistle. Was it methoxyflurane?
I was going to ask you what it was. It's the methoxyflurane. Okay.
I think. But I've heard nothing but great things about it as far as in the guys in Australia, Great Britain. I'm sure other places in Europe are using it as well. But super easy and kind of all the same benefits of the fentanyl lollipop in that you get too much, you can just pull it out, right? And then you starts getting a little light, you can stick it back in. Same kind of thing with the whistle. I don't know if I did a podcast on the green whistle, and so it was nothing but love on that side. I also did another podcast on sufentanil with Brad Morgan. The drug itself, I think, works great. How they've dispensed it is freaking ridiculous. Like, it is like the tiniest of pills in the biggest of packs, and I do not know how on earth it's not going to just fall out of, when you're trying to dispense it, because they're little. I used to have one up here, but the little dispenser it's not spring loaded, but there's a little catch on it. So when you're trying to push, it like launches that stupid little pill. And like even on the podcast, it like launched completely out of my hand. And now, this guy's just shit out of luck, I guess. But other than that, like that little pill, if a guy starts to get a little bit too much, good luck finding it. Good luck taking it out.
Yeah. I had a few years ago, got dysuvia, applicators. I had a very kind of similar experience to you. I really wasn't, I was in like the aid station. I was just like, screwing around with stuff and I'm like, hey, what's this? Dysuvia. And, I kind of rip it out of the package and in like 5 seconds, I like shoot the pill on the ground. I'm just like, this is a nightmare. What if it's dark or whatever? Or, you're running, that's whatever. I mean, it's just, I don't know. I just think it's that hair trigger for application. It's just with the catch you were talking about. It's too sensitive. It's almost like you'd have to put the whole thing in somebody's mouth and just let it dissolve or something. So I don't think there's anything wrong with the drug. I just think the originator needs to be changed.
Yeah, we need to just do something different about it. I don't know. Maybe a lollipop form of it.
Yeah. Maybe with some like Zofran swirl in there. So,
there you go.
Like, yeah. So it's like a soft serve ice cream or something. Yeah. Right.
You could put a little Narcan lollipop on the other side so it gets too much. You can just spin it around.
Yeah.
That's true. But so right now, when it comes to at least the new analgesic plan, short of IV medication, we're still trying to search things out.
Yeah, I think so. I think the search is on. I think people are still trying to figure out if we can still get fentanyl lollipops. I don't know if that's feasible either. So I think there's like kind of like a wide kind of enough chance to figure that out. But I do know, people are aware that, like all the smart people, smarter than me, they're trying to figure it out. And, cause it's not only like a medical problem, it's a logistic problem. It's an accountability problem. It's just kind of multi-comprehensive or multidisciplinary problem. So there's a lot of different, entities trying to figure this out. So.
Yeah. I mean, obviously, ketamine, not a bad idea. I think logistically it could be very helpful. Like they mentioned in the handout, at least I received, I don't know who made it, but they mentioned pre-filled syringes of ketamine. Again, I don't think it's a bad idea, but yes. I think it's kind of there's some dangers in only packing ketamine when it comes like ketamine and Tylenol are my analgesics. I think you might run into a problem with that.
Yeah, and ketamine is just, I think it's short acting. I mean, we give ketamine a lot in the hospital I work in, patients, and I mean, it doesn't last that long, even like a milligram per kilogram to sedate or to moderately sedate somebody. I mean, it only lasts 3 minutes for sedation. And so, I mean, I really think you're going to need like a longer acting opioid, especially, in the current situation we're facing or that people talk about with prolonged care, casualty care, whatever it's called, it's delayed care. You're not going to want to, especially if you have multiple casualties and you're by yourself. I mean, you don't want to have to like redose people, every hour. I mean, you're going to get tired, sleep. So, I mean, it's just something to consider. I mean, Dilaudid lasts a long time. Even if you can take oral meds, I mean, they last even longer, and you can control a lot of pain with Oxy or something else. So,
yeah. I mean, considering this is the United States and we have a plethora of pain control options.
Yes.
Why can't we pick one that already exists?
Yeah, I know.
But to be continued, I guess.
But to be continued. Yeah.
One of the other changes you had mentioned before we started was the analgesic, or not analgesic, the antibiotic section. Was there any, and they've taken, it seems like they're at least proposing taking Ancef off and just leaving Rocephin. Was there any real reasons why they did that, or is this kind of like a logistical thing?
So the current implementation was ertapenem in vans, and then it was kind of broad spectrum, and I don't think it was covering all the different bugs and stuff that needed covered. So they did basically, so we had some infectious disease docs, experts. Well, they were asked to kind of evaluate in vans against the current requirements overseas for bacterial control and contamination and all that stuff. And so they made this huge weighted matrix, which is basically you put all your requirements for, organisms on one axis. And then on the other axis, you put like ease of use, frequency of dosing, availability, you have to reconstitute it, stuff like that. And then you just weight all these different parameters, and then you basically calculate out which antibiotic provides the best coverage with the best kind of all the other antibiotic requirements you need. And then they kind of came up, I think you have the list with you, right? And came up with Rocephin, Invans and moxifloxacin, not recommended anymore, or they got removed. And we're going to look at, I think, Rocephin, PO antibiotic I wasn't familiar with. I think it's a cephalosporin though. And then, maybe you're wrong though, but I'm not 100% sure, but that's the reason why it got changed and what people I think can expect. Change in the PO and IV antibiotic.
Yeah. They did mention somewhere in here that at least we're considering vancomycin powder. I guess you just sprinkle it in the wounds. But no, they didn't mention anything other than that. At least they were looking at it. But currently, I think the big ones that they're wanting to propose, at least, there's three oral antibiotics, cefadroxil, cephalexin, and lizinolid. Yeah.
Zinolid, yeah.
Yeah. Were the oral antibiotics, and then Rocephin being the IV or IM at least the current recommendation. Yeah.
Yeah. I mean, Lurseffin's already a pretty well-known antibiotic to most people. It's more genetic. So, yeah, pretty easy. Yeah.
Yeah. Perfect. Any other changes or any other thoughts on what's likely to get through? What's at least in this next, the next voting meeting? Are they going to just focus on the chest, or are they going to vote on anything else?
I think we'll probably vote on chest. But we'll probably get an update on TXA. I think we're still trying to work. We can get TXA IM intramuscular.
Okay. So if you don't
to make it,
yeah, I was going to say, because there's like a big question that me and the other instructors are just beating our heads about. Why? Like, it's not just, can I? Like, yes, I can inject a person with TXA. That's not the problem at all. But if I'm giving this to somebody because they're in hemorrhagic shock, I don't understand why we believe it's going to get into the vasculature, especially when that muscle is not as well perfused. You know, I looked at the study, but I just don't get it.
Yeah. I mean, that is a very common question about it. I think there's kind of two reasons. One, TXA is really the only kind of like injectable hemostatic that's available. It's also, besides blood, it's really the only other way you can treat non-compressible hemorrhage. I think, unless you like count the pelvic binder or the sand binder or something, or the croc or something like that. But if it's not compressible, really the only way you're going to treat it is with blood resuscitation and TXA. So to make TXA IM, you could potentially allow people to self-administer it early. And I think you could also maybe like give it to CLS or a ranger first responder or, a team guy or whatever. Be like, hey, inject this guy with this in his leg or something like that. So it kind of broadens, who can give TXA as well. But I mean, obviously a lot of that stuff still needs to get worked out, right? Like, are you just going to like pass these things out on the battlefield or whatever? I don't know if we're at that point yet. We're still, I think, just trying to decide if it's feasible or if it's even,
Yeah.
Will it actually work if we even do it?
I mean, I think making sure, like, just like the tourniquets, everybody has their TXA injector. That makes sense, and you get them early before, cardiovascular collapse is when, before the medic shows up, right? So it's more likely to actually get into the vasculature and start working. That makes 100% sense. But just that, at least from the medic standpoint, one thing that we've been kind of beating our heads about is like, if the muscle's not getting perfused, we're not really doing anything, unless it's like some kind of like super lipophilic thing that will just travel without the need of vasculature. So that was something that was actually really confusing us.
Yeah. And I mean, I think it is. I think it's confusing to give IM meds in a shock patient. So, I mean, I'll agree with your guys' thinking. That's why I like to give ketamine IV. That's why I like to give, TXA IV. That's why, you like to give a lot of these medicines, IV or IO in lymphedema patients. So, yeah, I mean, I get the confusion. So.
Yeah, awesome.
Yes.
So chest TXA coming up for the next vote, or at least coming up in the next meeting. Anything else that's coming up?
Let's see. Not that I'm tracking. We're still talking about some triage stuff, which I'm pretty excited about because TCCC doesn't really have any triage recommendations. So I think I'll be interested to see what comes out of the meeting about triage next. So I mean, I would look out for that. And then there's a lot of smart guys, a lot of experienced guys working on the triage stuff, which I think will be a big deal, you know, in our LISCO environment or maybe our future operating environments. I just did a case presentation recently of a MassCal. It was in a civilian trauma center, but I mean, triage really was the key of this MassCal event, just to treat who needs to be treated. Don't treat the people who don't really need to be treated, you know, get them out of the hospital, get them out of the way. I think anybody, you know, listening or who's ever done a MassCal, I mean, there's just so many people and everybody's in the way. It's hard to get to people. You're stepping on stuff. You're kicking BVMs everywhere. And, so, I mean, triage is important to, you know, get the right people in the CCP, and keep the right people out of the CCP. So.
Yeah, absolutely.
So yeah, I'm excited about that. Yeah.
And, you know, we have that Walker dip happening in our force.
Yes.
So a lot of people who've experienced MassCals, whether in full disclosure, I've yet to, one, conduct or two, ever see a MassCal that was like, wow, that went really smooth. Like, good job, guys. I've yet to have that ever happen, but, I mean, incredibly relevant, not just military. I mean, geez, New Year's Day, you know, New Year's Eve, like we had a MassCal in New Orleans, 15 people,
yes.
15 people, like now, and you have all these casualties to sort through, you know, just having some kind of framework to work by that's at least been evaluated and tested in somewhat reality. I think it's going to be super beneficial.
Yeah. Yeah, it's just such a broad topic and it's just so individualized and so situational. I really think it's like the guy or gal who's triaging in the arena at that specific time and what makes the most sense. And I just think that's hard to standardize. It's hard to train. So it's an interesting platform, I think. Yeah. So I just think keeping it broad, probably be best, teach good principles, and guy or gal, on the ground, you know, they'll make the right decisions. So,
yeah. I mean, I think at least focus on, you know, a small scale MassCal, and you can grow from there once you get that down. I think, you know, it's, you know, like Doc Rush and Stacy Shackelford, last year, maybe even the year before, we were talking about like super MassCals of like hundreds of, like maybe even thousands of casualties. It like blew my mind. Like, I have no idea. Like, get trucks and start moving people. But if you don't have the basics of how to handle 5 people, you will never have the ability to handle that many.
Yeah, that's the, like the MassCal, multi-casualty, ultra MassCal paper, had a really well done one. It's really well thought out. And, you know, I think a lot of it's going to deal with, time. So you're going to triage by time. I think that's one of their, findings. So, you know, just due to the volume of people, wherever you kind of triage first and use all your resources on, I mean, that's your triage. Everybody else will either live without medical care or they'll die with the appropriate medical care. Unfortunately, I don't think a lot of people want to talk about it, or I don't know if that briefs well or it's on the right message for our strategic stuff, for our strategic initiatives. But I mean, I think that's just the reality of it. So,
yeah, you're absolutely right.
Yes.
You're absolutely right. And we don't like practicing it because we win, and that's what we like practicing on. So
yeah, we like practice winning. That's right. So,
but when is this meeting happening? Roughly?
Well, it's happening like in a couple weeks.
Okay,
so,
nice.
Yeah.
Yes. So
a couple weeks from now,
they vote. They have your meeting. They vote, yay or nay. If it gets voted up, then they put out a message on deployed medicine, or do they wait till they get the final wording and then put it out?
I think so. We'll submit final wording. You'll brief it or you'll present it, and then you'll find any alibis or anything like that. Tease out any final kind of red lines in the sand kind of thing. And then, like a week or two after, send out a ballot basically, and you vote yay or nay, and then that language is put into TCCC. I don't know the exact timeline of when it would get distributed, but or like when it would actually be published. That's kind of the senior committee members' job, but it would be probably this year. So it would definitely be this year. So
okay, well, awesome.
Yeah.
We'll definitely keep an eye out for it. Hey, John, I really appreciate you coming on.
Okay, Dennis, I always love coming on. Thanks for having me again. Yeah, I really enjoy talking to you.
Hey, thanks. Hey, happy New Year, by the way.
Yeah, you too. Yeah, Happy New Year.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.